All right, so welcome back. Hope you all had a nice lunch and you're still enjoying your gherkin, Dr. Trainer. Pickle, sorry. So I'm going to talk about aortic transfers. I doubt I'll make 45 minutes of this, but I think it's a point for discussion, particularly because essentially it's a pretty time critical, and the number of questions about who and when and where, because
I'm just testing.
If you work at Barts, you realise that all dissections happen at 3 AM and they always arrive with the blue cannula in the right hand, of also having had a sandwich and a plexo for that creepy. And the reason I'm talking about this is because, as well as a next consultant, I'm a ICU but also my anaesthetic practice is cardiothoracics and vascular. So yes, that's kind of most of my day job. Quick overview. Essentially, we're going to talk a bit about how aortic services have been essentially centralised, and so what that does to our geography and a few general themes. And then we're going to go through two specific pathologies, not just dissection, but also unruptured descending thoracic or abdominal aortic aneurysm. And I think there are two key questions that I think we need to answer when we're considering moving these patients. First one of which is, what do you need? And secondly, where can you add value? Because I think these are time pressured and time critical. And as per the discussion we were having earlier about moving of the MI, if we're moving them, we have to be adding something that they're not already getting. And I think this group of patients is interesting because actually the kind of approach to them varies quite significantly in terms of the geography, which I'll talk about. So, vascular surgery is and cardiothoracic surgery are kind of cohorted. I'm sure we will appreciate that. And there are various vascular networks across the United Kingdom. These are the main vascular surgical hubs. There are quite a few in London, but if you look out at what some of the distances involved, they're quite a long way, particularly if you look towards the east of England. So there are centres in Norwich and then Cambridge, and that essentially is almost 3 counties before you get across. Certainly if you are in Essex, you have vascular surgical access during the day at Chelmsford, Broomfield, Southend, Basildon and Harlow. Each of those hubs does a day a week on call. If you have a ruptured AAA in Canby, you are put in the back of an ambulance and then blue lighted with a DNAR until you arrive at Basildon if they happen to be on call. So that's 60 miles, quite a long way. And if you survive to arrive at that hospital, you'll get an operation. That's not the model that's operated in London. I think we are blessed by the fact we have a lot of vascular surgical access, but also that our distances are much smaller. But if you think about North East London, you're essentially talking about moving these patients into either the Royal London if it's an abdominal aortic aneurysm, or St Bartholomew's if it's a dissection or a thoracic abdominal aortic aneurysm. But it's not quite that simple because actually some things are more complicated, and so regionalisation of services has meant that where they're complex aortic aneurysms, you may be moving them into probably Tommy's south of the river, or Bart's north of the river. And that, I think, is worthy of discussion as to how things have ended up arranged, because you probably wouldn't plan it like this. Just a bit of kind of revision. So I think not all aneurysms are created the same, and certainly with the advent of the screening program, we're seeing more people for earlier procedures. I'm sure Dr. McKenna will also testify that actually we're trying to pick these people up at the point where their operative intervention is less than their annual rupture. So the screening program is men. It's men over the age of 60, and essentially anything above 5.5 is the threshold for intervention. And that's usually about 10% risk of rupture. But you can see how rapidly it increases in terms of, it's not a linear increase, it's pretty exponential. So by the time you're above 8 centimetres, you're running almost a 50% risk of death within a year. Thoracic aortic aneurysms are much rarer. For those of you who know me, you also know moving pictures that are in black and white. So you have stuff like this, and again, they're pretty rare, but they are often diagnosed late, and particularly for aortic dissections, thoracic aortic aneurysms are usually the main precipitant. So most people who have a dissection will present in a classic way. They will have the kind of tearing pain. They may also have end organ malperfusion, and I think that is worth thinking about if you're moving these people. So you can't necessarily rely on distal pulses or urine output because they're not necessarily connected to the circulation in the same way. So thinking about that is kind of relevant when we're moving them. And I think when you're thinking about moving these people, our degree of physiological stability may also differ from what we would accept in another different, because actually thinking again about what is our definitive intervention, we have no option for thrombolysis. We have no option for kind of something that can be done in the back of the lab. Their only option is surgery or interventional radiology. And so they have to get to a place of definitive care, usually very rapidly, before they have free rupture. I put this up just for interest. Kind of descending thoracoabdominal aneurysms are complicated and increasingly recognised, however, with the advent of kind of screening. So people who have abdominal aortic aneurysms detected on ultrasound screening will usually get CT angiography, and essentially it's working out how much of the mesenterics and descending thoracic aorta is involved. That's not to say this is common, it's not, but it's complicated, and so these kind of things usually managed in the specialist centre. Moving on to dissection, so hopefully we're all familiar with this idea. So a dissection is, I should have had this one first. So it is essentially a split within the vessel wall, and what you end up with is blood flow tracking between the endothelial, so the kind of layers of the wall, and creation of this true and false lumen. The true lumen is connected still to the left ventricle, so usually there's blood flow in it that is pulsatile. But the things that kind of get shaved off as this blood kind of propagates down might give you kind of atypical presentation. So we certainly see dissections that present with strokes as it dissects out your carotid. They may present with flank hemorrhage because of tearing off the renals, or they may have kind of other neurological manifestations if they lose blood supply to their spinal cord. So a degree of suspicion is pretty important for this kind of stuff, and not always easy to tell. So dissection is a great mimic. If you don't think about it, you won't. And as I'm jokingly say that they all arrive with a blue cannula, but virtually all of the aneurysms that dissections that we've had admitted over that we've all looked at this, one of our cardiac surgeons, and about 70% of people who had admitted with a dissection, they had antiplatelets, because people had thought that they were having an infarct, because all chest pain is ischemic. And we're not as good at, I think, identifying these, because you need to think about it in the first instance, but you also then do arrange a test. We're all told that MI is an emergency, and therefore treatment is kind of often instituted before you have all of the information. Certainly you'd institute treatment before you had an angio, which is the diagnostic test, and we'd all do that, and we wouldn't consider that. The problem as well is that a dissection can give you an MI. So if I show you this picture here, this is the aortic valve, this is your ascending aorta, this is your right ventricle, and this is your left. And here is where most dissections start. So they tend to start at the junction of what's called the sinotubular junction. That's also the point at which your right coronary comes off. So inferior MI is a recognised presentation of this. So it's all about the history taking. And if you've got someone who's shocked and unwell, actually you may not be in a position to kind of identify that. So who gets moved essentially? So I'm going to check these two things in kind of isolation. So we're going to talk about AAA first, so abdominal aortic aneurysm. So people get moved, generally speaking, where they need a diagnosis that can't be offered in the referring hospital or for definitive treatment. There's no evidence that any particular sign, symptom, or risk assessment tool can tell you whether someone who has an unruptured AAA, but a threatened kind of, so they may have pain or they may have a contained aneurysm, should be moved. But in practice, the people who get moved for consideration of surgery are younger. They're usually going to have something done, and they're not an extremis. Okay, which kind of is a self-selecting group. Because actually by the time they are in extremis, it's probably too late. They're probably going to die, and certainly the mortality of rupture is almost 100% if you're outside of a vascular centre. But also, there is an increasing availability of non-surgical options. So endovascular repair is probably now more, well, John will answer this better, I think more common for people who've got unruptured AAA because they tend to be older. They may have other organ problems, so kidney failure, heart failure, all that kind of thing. And actually, an infrarenal EVAR in someone who is older and frailer probably is kind of a better option. Certainly, they wouldn't necessarily be getting surgical repair. Yeah. And also, you don't necessarily need to do an awful lot to them. So actually, they can be done with relatively little physiological disturbance and actually very little anaesthetic. But the NICE standard suggests that you should leave within 30 minutes of decision to transfer. Practical? Nah. How long does it take? Usually you get an argument that you get in a theatre 12, they're coming. Yeah. So they may. So if you come in with the right presentation, so someone has to firstly think this is the problem. Someone then has to get enough of a diagnosis to be able to convince a vascular surgeon. Then have to get hold of a vascular surgeon. Then have to get that vascular surgeon to usually discuss with their consultant and accept. And then said vascular surgeon has to feed that back. And then you have to get the patient from wherever they are to their centre. And they don't always pitch up at the Royal London, they will often pitch up elsewhere. And the testing is variable. So most of the time, they're not going to take them with just an ultrasound. So you're going to have to get a CT. If you can get someone through CT in less than 30 minutes, you're doing well. Realistically, by the time you've got them in access, appropriate monitoring requested, they will inevitably ask what the creatinine is, and then you will have to get them to the scan, and then the scan back, and then the scan reported. Okay, so it's a challenge. Okay, and it's a standard we don't think we meet, and I don't think we meet it in London. Never mind Colchester. Yeah. What about dissections? So. Again, leaving aside the delay that you think, so who gets moved for a dissection? So this increasingly, so essentially it thinks about what's their intervention. So type A is pretty ubiquitously managed either surgically or with palliation, where patients are not. There is no medical management really of a type A. Type B, which I realised I didn't go back to my little picture. So type A, anything involving the aortic root. Type B, anything distal to the left subclavian. Surgery, or kind of medical management at your end. But as increasingly, certainly within our centre, we're seeing type Bs being moved for essentially availability of specialist care, blood pressure control, and then increasingly stenting, or where there may or may not be any local for cardiology vascular cover. So these patients are slightly different. Are you worried about them? How many moves have we done? We've done 4, I think.
Of type A's or B's?
B's. We don't think we've moved any type A's. I'm pretty sure we haven't.
We haven't moved any type A's. We've done about, I think 4 or 5 type B's.
Yeah, okay. So they're potentially pretty unstable. And they're probably the most time critical ones that any service does because we have no alternative operation. Because you have to move them before you get through rupture. By the time you get through rupture, there's nothing else that you can do. I'm going to mention this briefly, but not to kind of labour the point. And actually, there is a subset of people who have traumatic aortic injuries. We don't generally get involved in this, and certainly I don't think we've moved any of these. But there are patients out there who do have traumatic aortic injuries, and the only thing to be cautious about is essentially whether or not they're going to decompensate when you move. The reason I say this in bold is if you put a chest drain in these people, they may lose that tamponade effect and they may just exsanguinate. But I think the trauma service is pretty good about mopping these up, so it's just for interest. I don't think we'd necessarily be asked to move them. So what physiology do you want? Anyone done any dissection moves? All right, so I think that your aim is to try and minimise aortic wall stress, and the idea behind doing that is you both reduce the risk of rupture and you reduce the extension. And so the amount of shear stress that you have across the aortic wall is a function of your blood pressure times your heart rate. So you want a low heart rate, okay, and a low blood pressure, which means that your acceptability of distal organ perfusion may vary. So a systolic of 80 is probably adequate for most people, 70 potentially in some, but you're generally going to have to titrate it to consciousness rather than anything else. And urine output and distal pulses, as I say, may not be helpful because they may no longer be connected. And there are various ways to achieve it. The first and most important way, which is pain relief. So aortic dissection and aortic rupture AAA or contained rupture are painful. And pain, as we all know, is a sympathomimetic. They become tachycardic, their blood pressure goes up. So ensuring that you've got adequate analgesia on board before you then load them onto a trolley is really pretty key. We try not to fill them too much. So again, it's a bit like your first clot is your best clot in trauma. So you're going to resuscitate to a radial pulse in that setting, and that's probably adequate because that will probably represent a blood pressure around 80. But having volume available to give them if they need it is helpful. And the mainstay of kind of transfer is labetalol or other kind of short-acting beta blockers, plus. Why don't we use GTN first line? Anyone know? It's the heart rate essentially. So it's essentially trying to avoid that compensatory tachycardia. So it's not to say you can't use GTN, it's just that we will generally use a beta blocker in the first instance because it will give you that kind of relative bradycardia. GTN will be your second line. So what do you need before you move? So I'll put this to the crowd. Who needs an art line before they move?
Don't waste time.
Exactly, and I think there's the same comment that's coming in later, which is that remember when we heard Anne talk about it's not speed, it's pace. So you have to be adding value at each point. And again, we all would like, we would like a central line. Do we need it right now? No. Do you need an art line right now? Ideally, but what you don't need is to be spending 45 minutes at the bedside trying to put it in. Okay. You do need intravenous access, and you do need reasonable intravenous access, and you probably need two. One big, one ideally big, but potentially smaller. Because you want one for your infusions and one for volume. If you're getting beyond that point of needing two cannula to fill, I mean, you're kind of behind the curve, probably. The only caution I'd say with arterial monitoring is you need to think about what your location is. So if you think about your dissections, anything that is around the level of the subclavian on the left, you may lose that. So you may lose the pulse in the left arm. So ideally put it in the right hand. And certainly that's what we'd use in theatre. You need some antihypertensive medication, which, as I said, is pretty much always going to be labetalol plus or minus a nitrate. You might need blood. So a gas before you go, if you can get one. And again, not necessarily aiming for a hemoglobin of 8, but if you're in the kind of 10 range, it's probably worth taking a couple of units with you. Again, not to delay if you're going to just take an egg, to get the blood that is available for you, and make sure that you can then hand it over to your colleagues in the regional centre because they can use it and it can be booked in. And you just need enough of a history to be able to give a relevant handover. Hopefully they will know these patients are coming. There is a project going on with LAS about screening in dissections from the community and bringing them to an vascular centre. It's not currently up and running, but it's using ultrasound to kind of identify these people. Pain relief, so make sure you have some to take. But intubation is not really part of the story, okay? And the reason for that is if you think about the likely consequences of intubation and the hemodynamic effects, by the time you're getting to that point, they're probably dead. And they're also pretty challenging. If you think about your ruptured AAA, we would generally put them to sleep with everybody scrubbed, ready to go, and the tummy draped. So everyone is ready because when you paralyze them, they will lose that tone and they potentially will dump. So you need your surgeon ready with a clamp. You don't have that on the back of an ambulance. Okay, so if you're getting to that stage, it's worth a serious think about whether it's essentially in this patient's best interest to move, because what intervention are they going to get may be pretty minimal. What do you do though if they deteriorate? So if they deteriorate, first thing I would advocate is analgesia. Okay, these people are likely to die, and they shouldn't die in pain. So pain relief is the first thing. If they become more hypotensive, consider about whether you need or can give them any fluid or blood. But then it's a call into negative consultant or the kind of cardiac surgeon or vascular surgeon to say this patient is deteriorating, and they are likely to. We have certainly had deaths on arrival, and we had deaths in the ambulance, unfortunately, because people have decompensated on the way. And our interventions are pretty limited. I'm going to measure just this. This is what we do when they get there. So as I said, a large majority of contained rupture will be managed endovascularly. So it's usually local anaesthetic plus or minus a bit of sedation. They have an art line, they have a little bit of fluid, and they have an analgesic sedation strategy with something short-acting like Remy. Radiology will often go perc, so they can be very quick. They may need to cut down if their access is poor. So there's a surgeon on standby and the theatre team ready to clamp. And there are various things that you can do. So I'm going to mention this because essentially this is the kind of mainstay. So it's an EVAR, so it's infrarenal, and you put essentially one wire up each groin and then you deploy it. It's actually very rapid. There are fancier stents that people can have, some of which are pictures there. The important thing to say about these is these are not an option for people in kind of an acute setting. So if you think about all these people who've had thoracoabdominal aneurysms and that kind of stuff, these are custom made. They're hand sewn and they take 3 months to deliver. So you're not getting that if you have a complicated descending thoracic aneurysm, which is why we don't really do emergency type B surgical repairs, because the mortality associated with it is astronomical. So by the time they have rupture of their descending thoracic aneurysm and it's involving their mesenterics, you're pretty limited in what you can do. There are a couple of off-the-shelf options. So for this, you can either do something called a chimney graft, or I forget the word now. It's a chimney graft or it's a sweep. Basically, it's either whether you have this one long graft and then they put essentially that's a chimney into each one, or you have this kind of graft that has side branches. They don't fit everyone. They're actually quite complicated to put in. So that actually makes the whole thing a bit more unattractive, because actually the patients aren't really going to manage. Open AAA is, again, I'm not going to labour the point, but you're going to have to put them to sleep. So they may decompensate. You have to be set up for bleeding and aggressive warming, because they get cold very quickly. And they're either going to sew in something like a tube graft, which is that, or a bifurcated graft, which is that. For dissections, there are loads of options. So it really depends upon how far the dissection is and where it starts. There are various options. I'll show you the pictures, but they're just quite, I don't think anyone really explains the name. But there are a few indications for surgery in type B, which, as I say, is pretty limited. So essentially, major organ malperfusion, so they've essentially shaved off the mesenterics, impending or frank aortic rupture in someone who's fit enough, or a rapidly expanding false lumen, such that it's occluding the true lumen, and essentially they clot the aorta, but they don't do very well. Skip. Most of the time it's blood pressure control. As I said, there are a couple of endovascular options for type B. They generally speaking are managed conservatively until you can get a stent for them. And the mortality for a complicated type B is about 80 or 90%, even if you operate. You do it like this, so if you have to do it. So essentially you take blood out of the left atrium, you stick it around a pump, and then you return it into their femoral artery. You've got a set of clamps here, and then you usually clamp the bottom end. somewhere above the V, so somewhere above the femorals, and then you essentially open up all of this, and then spend a long time managing bleeding. There's a moderate dose to the Belmont. 43 litres of reinfuser is pretty standard. But they die usually due to blood loss. They may have an MI, and there's quite a high incidence of both stroke and late mortality. So I was asked, I got an email this week from a ED clinician in West London, and they were asking essentially whether we as Nectar actually transfer these patients.
Depends.
Is there a point? Do you think there's a point? What do you think we add?
I think you've got somebody who needs blood pressure control,
yeah,
and ongoing analgesia and of course,
yeah,
and the data we've got for our patch is the wait time on the appropriate admission to go in the back of the ambulance is significant.
It is.
And that's you know, if you need an escort,
yeah,
you need a discussion with the company. You need to have an escort at your hospital right now. And sometimes waiting 20 minutes for us to come is actually in the end delivering them quicker because all the other hurdles or other than that you're right.
And I think this is the point, that it is what value are you adding? We shouldn't, and I would advocate, will never add airway support. We may add some oxygenation support, so dissections where they get acute AR, they can get pulmonary edema, that can be managed. We do hemodynamic monitoring. We do hemodynamic manipulation, and I think we're good at it. I think we're also good at picking people up rapidly, as ably evidenced by Vicky earlier. And I do think that we are able to provide both, adequate analgesia, and where things are going wrong, a discussion about where this is going. Certainly, probably more than perhaps what often happens, which is that patients who are dispatched with ED nurses, usually they come without a doctor. And I think we do add some value there, and that's essentially what I said in my response.
I think, Jack, you can see why that clinician's asked that question.
Yeah.
You've got the Royal College of Emergency Medicine.
Yeah.
That has that as a
yeah.
Just transfer.
Yeah. The other thing I think we do is we minimise delays at the other end, because you're able to give a succinct handover. You've potentially provided some things to the other end which will be useful to them if you have had a time to establish arterial monitoring and it not to have taken a long time. But those things are important because inevitably you end up with, well, I can tell you what happens. They come and they are presented by people who don't know an awful lot about them because they've essentially had to move them quite quickly. We've gained a familiarity with that. We have gained a process of handover and are able to identify the relative positives and negatives more rapidly to a team who are usually pretty slick and usually expecting the patient. It's rare to get a dissection or a AAA without people knowing that it's coming, as again John will testify because he's waiting. So happy to discuss. It's, as I say, they're a small but I think important subset, and I think actually we may see more of this work as we start to swoop it up, certainly within the north of the river. But happy to take questions.
I think the mental model for a lot of people is, with regard to an escort, is if there's some decompensated rupture and they become unconscious. So, and regardless of how skilled you are, we can fix that. That's it. It's game over. And I think it's just appreciating that, I'm sure even if somebody sent a referring hospital, that's what they're worried about, is a rupture en route, or whereas actually, I've done ruptures and actually the less is more. But I think everyone's mental model is how I resuscitate this person if they collapse, and the reality is, without the surgical or the IR expertise,
you have no option. And that is not failing. That is just what you have.
What is the neck to death in back of ambulance?
0.
No, not as in like,
Oh, please.
but like LAS, if they have someone in arrest, they basically keep going until they get to,
Yeah, no,
they keep going until they get to hospital.
they're in a
because
very
then-
low flow state.
Yeah, so
Fine.
they have no option. They have to continue to
Yeah.
convey.
So if we're transferring someone and they decompensate,
Call the consultant.
call the consultant, apply diesel, and turn up at the receiving centre.
Yeah, but it is a conversation. And
Yeah.
I think that is also a place where we add value, because we could potentially have that conversation, and then you can say, look, we have tried, but we can't get them there, because they are not going to get an operation if they arrive arrested, despite what some of my heart surgery colleagues attempt. Oh, all vascular emergencies go to Basildon. Oh, nice. That is better. Still a long way. Still a long way from Canby Island to Basildon.
Question about marketing. Which blood pressure we target?
Right, Right, ready. Wherever that is, that's the root pressure. And so the ones that we've moved have all been type B. Yeah, so you can't be assured that the left one is on, and so we've normally done that.
Just like there's a national working group on sections, and they put out a paper in May, probably seen it. And it suggests in there that the adult critical care transfer certificate that exists in the region should take the lead on the decision making around transfer. So they should all be referred to Nectar or Referee or whomever, and then the decision making say, we can do this, you're available, or no, we can't. It's going to have to be local. But seeing as I now, as a consultant, am aware of this, I would like you to do following.
Yeah.
And I'm happy to do the comms, so that the receiving centre is apprised of your time of arrival, as John said. Hours go by wondering where they are.
Yeah.
And that's time taken up from the conventional suite, it's time taken up from operating suite, not doing other things. There's a cost to that on the patients, to the system.
I think there's a cost to the patient as well, because the more multi-organ fault, the more organ dysfunction that you accumulate because of ischemia, the worse this is going to be. And as I said, if you get them through the operation, they don't usually die of either heart failure or the operation falling apart. They die of strokes. They die of strokes and other ischemia, be it gut, be it kidneys, be it coronary. That's where they fall apart. And they usually die late, to be honest. Any other questions?
Just a comment here that we should potentially, I'm going to speak about drill cards a little bit later, but we need to probably make one about death in the back of the ambulance with a scenario like this, because it's the sort of thing where we can actually, where you say, having the conversations may actually avoid that scenario, which turns the ambulance into a crime scene and needs to be taken offline.
We're talking the corner.
I know you were telling me that you can now pronounce in the back. Or was it?
So it's only a crime scene. The crime has been committed.
Yes.
So
Chris.
crossing coronal districts with a deceased patient is not a crime in itself, unless there's reason to believe that that patient is somehow going to be referred to the coroner for criminal matter.
Yeah.
So if you have no pathology and an expected death, then there is no need to stay within that coronal district or proceed to the nearest ED. So if you not do best practice to certify a patient within that coronal district and then move a certified dead body, but you do not have to certify. You can seize suspect records. You can convey to the hospital of your choice, at which point when you arrive there, you can say, this patient is certified deceased. Now, it makes you uncomfortable 30 or 60 minutes or however long you're in the back and be deceased, but it is not a legal requirement to
They're not dead till you say.
So our SOP is you follow over, you discuss it with the duty consultant and decide. I'm going back to where I started because that's where the patient family is. That's where they already have records. Patients already logged in there. to either proceed to destination because it's just that much closer. I've already travelled an hour out of 5 minutes left to go. And then there's a question of where do you go there? Is it ED? Is it to the receiving units? And that's, we decided that's going to be about individual circumstances because it's so rare. Probably ED because just from the ED entrance into resus is a secure route pretty much. You don't want to be taking a dead body through the main corridor case along with CCUB. That's where the beds are going to be. So we've left that potentially. We can share that.
Yeah, please.
We haven't had a case yet, as we felt that would. We all will at some point in time. It's going to happen. And that's the word from the medical examiner box in the corner through the institute.
Awesome. Yes, please.
We've had a test for dead kids. We have agreement and London that stop resuscitation. We don't normally, but you can stop resuscitation if it's not in their interests, and they will take them straight in at an ED. That shouldn't be questioned. They'll have, so all the EDs have a pathway for that to happen, and we would just, I think for Nectar we would probably just use that pathway to the ED. But as Pete said, it's a consultant conversation because it may be better to turn around rather than carry on. It just depends where you are in the journey. If you're on a long range, the local.
Stick with you guys because you guys pretty much are
Pretty nuclear.
90.
We're pretty nuclear.
Northeast London,
Yeah.
whereas only 50% of our work is within Southeast London.
Yeah.
So it's A, more likely to die with us, B, more likely to be crossing through.
Yes.
The one that there's a big card for that we'll have soon will be a DNA CPR that dies on the way. So that, well, obviously we're not going to resuscitate, but actually
Then what?
we should rehearse through
Yeah.
the
Grand.
Use quality as a broad exclusive rather than
Sometimes it can just be a bit unforgiving if they're about to tamponade. That's the short answer. Sometimes. Most people arrive on the beat floor, and most people arrive pretty blocked actually. One last word of caution. So dilute the beta floor can get through quite a lot quite quickly. So, and it has to be diluted into a litre. So just make sure you have enough of it, because if sometimes they're on 400, 500 milligrams an hour, that's like half a litre almost. So until you get central access, so yeah, you can end up giving quite a big amount of volume, quite sharp. Stunned silence.
Excellent, thank you.
Between the cardiac shock and the AAA.
And the need.
Coffee break for everyone. Back at 2 o'clock.
Yep.
All right. See you then. Such a cheerful season.